pleased to introduce our next speaker, Dr. Amit Tirosh. He graduated from Hadassah Medical School in 2007 and specialized in internal medicine and endocrinology. Dr. Tirosh trained in managing endocrine cancer and cancer bioinformatics at the U.S. National Cancer Institute from 2015 to 2018. Dr. Tirosh is an associate professor of medicine at Tel Aviv University and a director of entire Translational Research Center for Endocrine Cancer, where he established a neuroendocrine tumors unit and the VHL clinic at Sheba Medical Center in Israel, and opened a research lab focusing on hereditary endocrine cancer syndromes and specifically on VHL-related endocrine tumors. In 2018, the VHL clinic was recognized as the VHL Clinical Care Center by the VHL Alliance. Dr. Tirosh was a member of an expert team developing the clinical recommendations for VHL management for the VHL Alliance and led the subcommittee responsible for the VHL-related pancreatic manifestation management recommendations, which were published in 2021. So with that, Amit, welcome, and you have the floor.
Thank you very much, Mike, for this very, very generous introduction and for inviting me to speak today. So I hope you see my screen okay now and that you hear me okay, because I saw that there were some comments on that.
Everything is good.
Great. Okay, so a few months ago, I chose the title for the talk, and it was the quest after the oncogenic drivers for VHL-related pancreatic neuroendocrine tumors. And after some thought, I chose another title, VPNET, from a different angle. So first, I have nothing to disclose, of course. And I thought that it would be very interesting or more interesting to look at VHL pancreatic net from the perspective of sporadic pancreatic net, the difference between sporadic and VHL-related PNET. Because as you will see in the next slides, we can learn on the pathogenesis of sporadic pancreatic net from the VHL PNET and vice versa from VHL on the sporadic. So I'll give a brief introduction on pancreatic neuroendocrine tumors and on VHL-related pancreatic net. Then I'll speak briefly on several possible drivers for the genesis and progression of VHL-related PNET. Again, I'll focus also on sporadic pancreatic net to raise some ideas. And then I'll speak briefly on possible cell of origin of pancreatic net and the question that it may raise on VHL-related PNET, and summarize with some future perspectives. So when we are talking about neuroendocrine tumors, we are talking on a relatively rare type of tumors, very heterogeneous group, with an annual incidence of about 7 per every 100,000 persons. And the pancreatic net is a small fraction of the entire group or family of neuroendocrine tumors that constitute about 3% of all pancreatic neoplasms, with the majority is a much more aggressive and known pancreatic adenocarcinoma. And pancreatic neuroendocrine tumors emerge from the endocrine islet cells, which include several types of cells. We usually talk about the alpha cells and the beta cells. Each of the cells in the endocrine pancreas may or may not secrete some types of hormones. The beta cells is well known, especially in Canada, for secreting insulin. And when we are talking about the tumors, we are dividing them in some of the classifications to functional and non-functional. And by functional, we mean that they secrete some types of hormones that lead to clinical syndromes. So most of the pancreatic net in general, the sporadic pancreatic net, are non-functional. But there is a fraction of these tumors that do secrete insulin or gastrin or glucagon or VAP and other hormones or compounds that lead to clinical syndromes. So sporadic pancreatic net are very heterogeneous. And this can be based on the grade. It may be very low grade with indolent disease, or small pancreatic net that may be stable for many years. And on the other side of the scale, then may be fully differentiated, highly aggressive tumor that can progress in a matter of days, and we consider them more or less like adenocarcinoma of the pancreas. The PNET may also differ in stage. It can be localized representation or metastatic representation. They can be functional or non-functional, as I mentioned before. And the natural history of the disease can change as well. For instance, gastrinoma may be in metastatic in higher rates than other tumors. Insulinomas are typically solitary and only in very small fraction and metastatic, etc., etc. So this is only to show you that sporadic pancreatic NET are heterogeneous. Now, when we're talking about pancreatic NET in the context of von Hippel-Lindau, we have to start from the manifestations in pancreas in general. So about 35 to 70% of the patients with VHL will have some type of pancreatic manifestations, but most of them will have cystic disease, which is almost always not a non-open tumor. Pancreatic NET is found in 8 to 17% of the patients with VHL, and then they might be multiple in 30 to 50%, but in only a very small fraction of the patients, it can be metastatic during lifetime, in less than 20% of the patients. So if we're talking about VHL-related pancreatic NET and compare them to sporadic pancreatic NET, we can see that high-grade disease is almost never seen in VPNET, in VHL-related PNET, and might be seen in sporadic PNET in a significant percentage of the patients, in 7%. Functional PNET are almost never seen in the context of VHL, but are seen in about 10% of the patients with sporadic disease. And metastatic disease, again, is much more common in sporadic pancreatic NET with about 40% of the patients, which is higher than the number of patients with metastatic disease in the context of VHL. So what I want to show here is that VHL-related pancreatic NET seem like a specific, very unique, very homogeneous subclone of sporadic pancreatic NET. They are not similar. They might be either a very different disease or similar to a very small portion or a very small clone or phenotype from the sporadic group. So the question, what can we learn from sporadic pancreatic NET on a VHL-related pancreatic NET? So let's start from a brief background on what we know about the genetics of sporadic pancreatic NET. So this study that I will show here will repeat several times in this talk because this is a pivotal study in the field of pancreatic neuroendocrine tumors. And this is a work done by Aldo Scarpa and his team. It was published in Nature in 2017. And they performed whole genome sequencing for about 100 samples of pancreatic NET, non-functional pancreatic NET. And as you can see in this figure, they found mainly based on the somatic alterations in the tumor, they found 4 main mechanisms leading to PNET development, and which included the chromatin modification, DNA damage repair, altered telomere lengthening, and the mTOR pathway signaling. And alteration in each of these pathways or mechanisms may lead to sporadic pancreatic NET development. And as you can see, there is no direct connection, genetic connection in between the VHL or pseudohypoxia and sporadic pancreatic NET. So here we don't see anything direct, and definitely we don't see any alteration in the VHL gene itself. But when you look at the RNA-seq data in the same work, they did a network analysis based on the transcriptomic data. You can see that from the 31st pathways identified or enriched according to this data, about a third was related to hypoxia, and additional 40% from the first highly enriched pathways were metabolism related, mostly glucose and carbohydrate metabolism. So we don't see a genetic link between VHL and sporadic pancreatic NET, and when we look at the gene expression and transcriptomic data, we see very clearly that hypoxia and metabolism, glucose metabolism, is is indeed related. And the question raised is, what is the link here? What leads to this transcriptomic change in sporadic pancreatic NET? And why don't we see the VHL here? So the first automatic option that may be raised is that it might be epigenetic. And if you look at the data from the same study, you see here on the right, I don't know if you see my pointer. Here you go. So you can see here the germline variants in the VHL gene. So there were very few. And here you can see some somatic alteration. So this is the MEN1 gene. And you can see that there is very often either somatic alteration or copy number loss in the area encoding the MEN1 gene and the menin protein. Now, the menin protein is important because it is very tightly associated with the DNA methylation. And there is very nice work done by Dr. Steve Libut and his team showing that MEN1 loss is associated with a genome-wide DNA hypermethylation, and they did it on a parathyroid tissue. And you can see it here in this figure. Green is for hypermethylation, red for hypomethylation. The outer circle is for normal parathyroid tissue, and then parathyroid adenoma, parathyroid carcinoma, and the inner circle stands for the MEN1 related parathyroid tissue. And you can see that with MEN1 loss, the DNA is almost completely hypermethylated. And they did several studies, and they suggested the downregulation of the DNA methyltransferase 1 might be associated with this hypermethylation. But in sporadic pancreatic NET, the hypermethylation is not only genome-wide, but also specifically in gene promoters that are clinically relevant. For instance, the MGMT, encoding the MGMT enzyme, of course, is very relevant for us because we're using temozolomide, in which MGMT expression might lead to resistance. And the SSTR2 is a target for treatment in sporadic pancreatic NET. And hypermethylation of the SSTR2 gene promoter may lead to, again, to resistance to the treatment. So we know that the hypermethylation is a key factor in the sporadic pancreatic NET. And we also know from recent studies on cell lines that the treatment with methylation inhibitor may lead to increased expression of the SSTR2, and this again might be very important clinically. So in sporadic pancreatic NET, they are characterized by DNA hypermethylation, potentially of clinical importance. But then when we go to the VHL-related Pancreatic NET, we see a completely different story. If you look here, we see a DNA methylation study that we performed at the Dr. Electron Kebebu lab during my time at the NCI. And you can see that the sporadic pancreatic NET and the MEN1 related pancreatic NET, they group together in this analysis, whereas the VHL groups completely separately. And in this heat map, you can see again that MEN1 related pancreatic NET and sporadic pancreatic NET have relatively hypermethylated CPGs. But in VHL, you can see almost entire genome hypomethylated. And when we did analysis specifically for the gene promoters, you can see again that MEN1 and sporadic tumors have a similar promoter gene methylation, whereas in VHL, you see that relative, the average, it's not a gene-specific analysis, but you can see hypomethylation. So this hypomethylation might be secondary to some factor, to some secondary transcription factor that is more active in VHL than in sporadic tumors. But it might also be a part of a VHL-related pancreatic pathogenetics. I don't know the answer, but the huge difference in the DNA methylation between sporadic pancreatic NET and the VHL-related pancreatic NET definitely raises this question on the role of this change. Another factor that might connect the loss of a VHL and development of a pancreatic NET that we don't see genetically is a metabolic change, because this is of course very well known and studied that there is a metabolic shift in VHL-related tumors for many reasons. And this work done by Yuval Yosef, a student in my lab. We are trying to study the metabolomics of VHL-related pancreatic NET and compare it to the sporadic counterparts. And this analysis is based on 20 VHL-related samples and a few sporadic pancreatic NET. We performed a metabolomic analysis of polar metabolites. And you can see here in this heat map, first, there is a organ-specific clustering of the metabolomics. You can see here a few hemangioblastoma clustering together and few renal cell carcinoma, all VHL related. And here on the left, you can see in green few chromocytomas that are again VHL related, but you can see also the VHL related pancreatic NET here in pink. And here you can see the sporadic pancreatic NET, each of them cluster together. So there is both organ-specific metabolic clustering and different clustering between the sporadic and VHL-related pancreatic NET. And this suggests that the metabolic change is still unique for the VHL-related pancreatic NET, and you don't see the same effect in the sporadic group. And with further analysis, we identified one specific metabolite that might be a suspect for driving the tumor genesis in VHL-related tumors, because it might be an activator of the mTOR pathway that, as I mentioned before, is associated with sporadic pancreatic NET development. And we are currently studying it both bioinformatically, but also in some interventional studies. A third option that might explain the higher likelihood to develop a pancreatic NET in the cases of VHL loss in patients with VHL is the tumor microenvironment, the immune TME. So in sporadic pancreatic NET, it is very well known, again, very thoroughly studied, and proven that there is a cold immune TME. This is grade dependent, so the higher the grade is, the higher the likelihood we see tumor invading lymphocytes or neutrophils, etc. And the higher the chance that we'll see PD-L1 expression that might enable us to use immune checkpoint inhibitor. But in clinical studies on PD-L1 inhibitor, you can see in brown that most of the tumors checked here were PD-L1 negative, and overall the results from immune checkpoint inhibitor in sporadic pancreatic NET, the results were very disappointing, and practically we do not use them at all. So the question is, if we already know that in sporadic pancreatic NET, the chances or the immune milieu is quiet, there is no immune cell activity, why should we check it all the situation in VHL-related pancreatic NET? And the answer is that in 2020 and before, of course, but in 2020 there were two publications by the teams led by Dr. Ian Fu and by the team led by Eric Jonash. And they demonstrated each in their own work that the HIF1, HIF2, VHL, and also VHL versus PD-L1 may alter the immune patterns or immune activation in the various tumors. And so we took the idea to pancreatic NET and wanted to see whether in tumors deriving from patients with VHL, we'll see a different or distinct immune cell composition compared to the sporadic pancreatic NET. And this study is funded by the VHL Alliance, and we are very, very thankful for them because it was a pilot grant, and I'm not sure whether people understand how supportive this pilot grant is, because it really can change the path of entire lab, and I'm saying this for firsthand and own experience. So thank you for the support. Now, in this work, our goal was to characterize the immune patterns, the PD-L1 expression, the immune cell composition in VHL-related and sporadic pancreatic NET. And the first thing that we saw that in sporadic pancreatic NET, there was higher expression compared to VHL-related pancreatic NET, meaning that if we barely see PD-L1 expression in sporadic pancreatic NET, in VHL-related tumors, we expect even to a lesser extent. And this is important. And the other thing that we saw that there was higher representation of CD4 cells and of NK cells in sporadic pancreatic NET compared to VHL-related pancreatic NET. And we're still gathering the data, but I cannot say something specific on the activation of the immune system in VHL-related pancreatic NET. For one main reason, we used methylation data and deconvolution algorithms. And in contrast to the transcriptomics-based deconvolution algorithms, it's much more difficult to say whether the cells are activated or resting, and the resolution of identification of these cells is lower compared to the transcriptomic-based deconvolution algorithm. But we can definitely say that the immune character of VHL-related pancreatic NET is different from sporadic pancreatic NET, and this is important for us to know. I don't think it was shown or demonstrated in the past. Now, there is another topic that, again, we don't have answer for, but all the questions that I raised, these are topics that are open for research and that we're trying to answer in our work at the lab. But this is another question that we don't have answer yet. And it's quite a hot topic in the field of neuroendocrine tumors. And the question is, what is the cell of origin in pancreatic neuroendocrine tumor? Because if we are talking about non-functional neuroendocrine tumor, they may emerge from each of the several cells that reside within the endocrine pancreas. But if it is a functional tumor secreting insulin, then I know that the cell of origin was a beta cell. And if the tumor secretes glucagon, then I can assume that the origin is alpha cell. But in any other case in which the tumor is non-functional, I can only speculate on the cell of origin. So you can see here work by De Domenico that was published in Communication Biology 2 years ago. And here they based the analysis on DNA methylation data and identified the cells according to the patterns of the CpG methylation, and using some other immunohistochemical and other modalities. And you can see that they identified a fraction of the cells as beta cells and another fraction as alpha cells, but a large number of the other cells were indeterminate. Some had alteration in ATRX and DAX leading to telomere lengthening. Some had MEN1 mutations that probably led to epigenetic changes, as we saw before, but it did not have any specific clustering. And they came with the idea that some of the cells emerge from alpha cells, and then with MEN1 mutation and DAX ATRX mutation can become one type of cells called ADM for ATRX, DAX, and MEN1. And the other type of tumors begin from the beta cell and become pancreatic NET. A few of them are insulinoma secreting, but some of them may be non-functional pancreatic NET. The important point is that they demonstrated that the alpha cells are of high risk to recur or to progress. And there is at least two studies. There are at least two studies showing that the beta cells almost never progress. The alpha cells do progress eventually, but there are a large group that did not fit either to alpha or beta cells had the high risk, and this might be related to the differentiation of the cell of origin in this tumor, but it's again only speculation. Now, the question when we're talking about VHL, the interesting question is where did the VHL-related pancreatic NET come from? Where do they come from? And this is mainly interesting because of the homogeneity. In contrast to sporadic pancreatic NET, which are very heterogeneous and probably come from a variety of cells in the endocrine pancreas, here we are talking about mentioned before, well, maybe too ambitiously, but the subclone of this tumor. And it might be interesting to see whether we can identify the single one cell from which a VHL-related pancreatic net develops. So if we're talking about the future perspective based on these open questions, so the question is, what is the origin and of course oncogenic drivers for VHL-related pancreatic net? So at the moment, I don't think we can determine them. Most of the studies that we have been doing until now, which are much easier, of course, are descriptive. We can characterize the methylome. We can try to use deconvolution algorithm to study what is the composition of the tumor, but trying to alter the genetics of the cell, trying to find models to study it is much more challenging, but then might lead to much more impactful results and data. And the third point is, of course, that accurate cell characterization studies and mechanism focused experiments are needed, and this is more or less what I just said, that we have to invest more time, effort, and thought in the experiments to reach meaningful results. And I took the old statement from the VHL Alliance, curing cancer through VHL. I think it's very true here, because if we can learn from a VHL-related pancreatic net, what makes them so silent most of the time, and indolent, and not secreting, and low grade, and somehow takes this to the sporadic pancreatic net, mainly those that are more aggressive, then we can practically cure cancer through VHL. And this is definitely very challenging, but interesting goal in our group. So I would like to thank you for listening, and I would like to thank our patients. And two important things. First, for the VHL Alliance, Dr. Iliopoulos, Josh, and all the team for the constant support, silent support, and the overt one. And the VHL community in general, Dr. Tirosh for the advice, and many, many others that are always available, both in clinical matters and research matters. It's not going for granted at all. And thank you very much.
Thank you for that wonderful talk. Any questions from the audience? Maybe I'll start off. Amit, you mentioned about hypomethylation difference between VHL-specific PNET versus sporadic. You also indicated PBRM1 for VHL-related, which may lead to perhaps hypomethylation. Have you also looked at DNMT1 and/or 3, these DNA methyltransferases, how they differ between VHL-specific versus sporadic?
So great question. The answer is not yet.
Okay.
But we'll definitely do so.
Okay. Do you think these are potential candidates that might be responsible? Do you have any guesses?
So PBRM1 is definitely a possible candidate because of the loss of the 3P chromosome, but in terms of the DNMT1 and 3, the loss in MEN1 related pancreatic net led to hypermethylation. So unless there is overactivation of these enzymes, I don't see, I'm not sure how they might be related to VHL related pancreatic net. Yes. And very frankly, I'm not sure if the hypomethylation itself is a causative factor for the development of pancreatic net or just a bystander. It is interesting. It is an interesting finding, but to take it as a part of the mechanism, the tumor genetic mechanisms, I'm not sure if we can do it at this point.
I have just another a naive question. Is there an animal model for PNET? And
in general or VHL related?
Oh, in general, let's start with
in general. So this is not naive at all. There are organoid, so animal models. There are few. The most renowned one is the MEN1 deficient mice. And they tend to develop tumors in the pancreas. But as we all know very well, that even the MEN1 deficient mice don't develop exactly the same phenotype as we see in patients. And I know that there have been some experiments trying to develop mice lacking the VHL gene, but I don't know of any VHL-related pancreatic NET mouse model.
I see. Okay. Thank you for that.